¿Qué tal?
Que te pongas ahí, porque están transmitiendo.
Ok. ¿Dónde está la...? Bueno, en fin, no importa. ¿Qué tal a todos? Buenas tardes, gracias por estar aquí. Hoy tenemos un coloquio bastante especial. Si se fijan, hoy este semestre tenemos un coloquio extra y es en parte debido a este evento y se hizo una acreditación internacional para el programa de física médica, para graduados en física médica de todo el país, de hecho. Afortunadamente muchos de nuestros egresados, o sea, de nuestro posgrado, tomaron esta acreditación y por supuesto eso nos llevó a tener a un experto internacional en el tema dando este coloquio hoy, lo cual para nosotros es bastante bueno. Hubo otro coloquio del otro especialista que vino a principios de la semana aquí en el instituto, entonces eso también nos permite de nuevo ofrecerles a ustedes otro tipo de pláticas también más especializadas, pero de nuevo relacionadas con la física, con lo que ustedes hacen y en esta multidisciplina que dicta nuestras investigaciones actualmente, pues siempre se les ofrece a ustedes un panorama más amplio de lo que se hace. Yo voy a dejar a la doctora Brandán que les presente a nuestro expositor, ella lo conoce mejor que yo y además es la encargada la responsable de toda esta organización de esas acreditaciones y por supuesto eso se lo agradecemos muchísimo, permite seguir manteniendo el nivel de nuestro programa en física médica y en general de nuestro posgrado y a ella le corresponde en esta ocasión presentar con toda propiedad a nuestro expositor, quien se quedará con ustedes. Gracias por estar aquí.
Muchas gracias, doctor Reyes Esqueda. Es un gran placer, como lo explicó Alejandro, tener aquí a nuestros dos visitantes, el doctor Carmelo Caruana de la Universidad de Malta y nuestro ponente en este coloquio, el doctor Adel Mustafa de la Universidad de Yale. Ellos vinieron a aplicar un examen de certificación que ocurrió el fin de semana pasado. El doctor Mustafa es profesor asociado del Departamento de Radiología y de Imagen Biomédica en la Facultad de Medicina de la Universidad de Yale y es director de Física del Diagnóstico Médico en el Hospital Yale New Haven en el estado de Connecticut, en Estados Unidos. Él obtuvo su maestría en Ciencias y su doctorado en Ciencias, específicamente en el tema de Física Médica de la Universidad de Surrey, en el Reino Unido. Su historia reciente de carrera académica y en el hospital incluye posiciones en la Facultad de Medicina de la Universidad de Kuwait y en el New York Medical College. El doctor Mustafa tiene certificación de colegio, es decir, Board Certified, por el Colegio Estadounidense de Radiología, el ABR, y por el Colegio Estadounidense de Física Médica, en Física de la Imagen Diagnóstico. El doctor Mustafa es Fellow de la Asociación Estadounidense de Físicos en Medicina, AAPM. Por más de 25 años ha servido como miembro, codirector o director de varios de los comités profesionales y científicos que mantiene la AAPM. En particular, él forma parte de los profesores que examinan dentro del Board estadounidense de Radiología en temas de física de la imagen diagnóstica y donde él dirige lo que es la parte 3, que es la parte final del trío de exámenes que constituye una certificación desde el año 2004. En particular, y relacionado con el evento que tuvimos este fin de semana, él es miembro del Comité de Acreditación y es jefe del Comité de Exámenes Orales del Board o del Colegio Internacional de Certificación en Física Médica, que es la organización que vino a aplicar los exámenes. Sus intereses actuales en cuanto a clínica, enseñanza e investigación incluyen la optimización de la calidad de la imagen, el manejo de la dosis de radiación y la cuantificación de las condiciones asociadas con enfermedad usando modalidades múltiples de imagen con un especial interés en imágenes por CT, que es tomografía computada. Actualmente dirige un grupo de físicos médicos en la Facultad de Medicina de Yale y colabora con científicos, radiólogos y médicos clínicos en área de detección por CT, cuantificación y optimización. El doctor Mustafa es de origen palestino. Muchísimas gracias.
Okay.
You are very welcome.
Well, thank you so much. I really appreciate this introduction, although a little elaborate, I guess, but it will do the work. And also, I'd like really to thank you, Professor Brandon, for receiving us here and taking care of us during the exam, as well as showing us around the university, as well as around the city. We really love what we have seen and hope that this will become really some kind of an initiative with which we will have more collaboration at personal level, institution level, as well as international level.
So my pleasure.
So thank you so much for that. Now I understand that we have a mix of students as well as professionals in the group in here, and some of you are medical physicists, so it will not really be that difficult for you to follow what I'm going to be saying, hopefully. But I also understand that some of you have had really no particular experience with medical physics. They did not work in the area of radiation medicine. And so there will be an opportunity for you just to see and feel what we are actually doing in this particular area of diagnostic radiology. And this is not really so much of an easy topic to talk about, but I will start with introducing some basic concepts for the benefit of those of you who did not have knowledge and expertise in the area of diagnostic radiology physics. And that will take about 15 minutes, but then after that I will go into talking about the actual substance of the presentation.
To stand there for the camera.
Okay. Here, there, okay. Right. That's fine. Okay. Well, very good. Thank you. So the first 15 minutes or so, I'd really like to focus on just giving everybody a feel of where CT belongs in diagnostic radiology and how you can, if you know what is general radiography, you should be able to have some extension from your understanding of general radiography to the field of X-ray CT. So to start with, I'd really like first to acknowledge some people who lended me some material. I used some of their material, changed it, added to it, and eventually came up with this particular presentation. We have a cooperation agreement with a particular vendor, and that has been actually helpful for us to apply the clinical part of dual energy CT in our environment. So to start with, let's define here what is the clinical image. What is a medical image, basically? And all understanding says that it is a window into the human body. That's really, we wanted to see what is inside of the body there, and for the purpose of making diagnosis of pathologies, abnormal conditions in the body, as well as being able to use diagnostic tools for guiding treatment therapy. This is what physicians want us to do, or want radiology providers to do, tell us what's happening in there, and at the same time, help us understand how we can use this knowledge for treatment of our patients. And different medical imaging modalities employ different technologies, employ different techniques, imaging concepts, a lot of science behind that, a lot of engineering behind that. Eventually came up with all those what we call imaging modalities. Now, it tends to be that none of the imaging modalities can actually answer all questions related to what is happening in the body. What we are looking for usually, things related to morphological and pathological characteristics of tissue. This is a list of things that we are trying to achieve. We want to have a modality that can give us anatomic information, functional and physiologic information, metabolic if possible, molecular, and some people even venture and say genetic information can also be obtained using those medical imaging techniques. I did not really come across that in details myself, but a lot of our imaging modalities can actually achieve, if not one, multiple of those goals or objectives. So for instance, in here, if you look at this list of medical imaging techniques we employ, this is a general radiograph, so as that one in there, and this is also a projection radiograph of the breast, and that is a CT scan. So as you can see, common among those modalities or variations of those techniques is the fact that all of them use X-ray as the source of radiation or the prop in here. But then why want to go from a chest radiograph like this to a CT scan? There are things that a chest radiograph can actually reveal and show us, but it actually fails to show us the better contrast resolution which we are looking for. And CT, as probably you know, came back because of the fact that when they used to do skull radiographs, they used to see nothing, no details inside of the brain, gray matter and white matter and CSF. All those variations are not possible to see and achieve if you just do a general radiograph. So they went into looking at ways and methods for being able to delineate and identify those tissues and see those tissues and variations from within. Not only that, we also went into not only looking at X-ray radiations, but also other sources, including gamma radiations in nuclear medicine, radio frequencies, which we use in MRI, as you can see in here, even non-electromagnetic radiations like mechanical waves, including sound waves. So all this is done because of the fact that none of those windows is a perfect window that can answer all questions. So that's why, you go to your doctor, you start with a chest radiograph, maybe, they suspect something, they say, well, okay, go and do a chest CT, for instance, for the fact that that chest radiograph could not really accomplish and give you all the answers that you want to get. And of course, with time, they build some kind of protocols and algorithms, knowing how to go from one imaging modality to another imaging modality related to specific disease and conditions as well. So let me bring this kind of comparison between general radiography, keep touching that thing, between general radiography, the way probably a lot of us have experienced it as patients even, and X-ray CT, which is the subject of our discussion. Basically, you have in any of those, whether this one or that one, a source of radiation, a beam comes from that tube, and a distance you have a patient. On the other side of the patient, you have a detection system. Now that beam contains so many rays. One thing about this particular configuration is the fact whether the patient here or the patient there, patients are 3 dimensions, aren't they? I mean, we have the length of the patient, we have the width, and of course we have also the transverse direction. So the volume of tissue now coming from the patient will have to be projected into a 2-dimensional receiver. What happens to the 3rd dimension, which is usually the depth dimension, right? Is actually going to be superimposed, which means that anatomy from the bone and the lung tissue and the spine in the back, all of them are going to appear on the same radiograph. That is one big hurdle when it comes to even reading a normal radiograph, not even pathology or disease. It takes radiologists some time for them to recognize how normal anatomy looks like. So with this, in this case, we're going to find that we have an issue that's really something that we could possibly resolve using CT. Why? Because in X-ray CT, what we basically do, we preserve the depth direction, we preserve the transverse direction, but we basically narrow the 3rd dimension, which is the length dimension, all the way down from about, let's say, 17 inches, about 40 centimeters, to something like probably 1 millimeter. And in this case, our images will be obtained from thin slices in X-ray CT rather than volume of tissue. So that's an approximation that helps minimize the effect of superimposition of structures on those particular images. If you compare here the voltages used with our radiography and CT, we can go all the way down to 40 kilovoltage, and that's the operation voltage of the X-ray tube. And the same thing in X-ray CT, except for the fact we don't really go as low as 40 kV because we need a harder beam in CT, and we need also more quanta. We need more radiation to produce our images. So that is something that we don't really want to do, lower energies. Another thing also, when you do this radiograph in here, you're going to end up with producing a single shot. You only have one shot to produce a radiograph, and during that time, nothing should move, meaning the X-ray tube will not move, the detector will not move, the patient will not move, to the extent you just tell the patient, do not even breathe, right? I mean, you just say, hold your breath when you do those radiographs. Similarly in CT, by the way, something like this will also happen, except for the fact that X-ray tube in here and the detector there are going to be rotating around the patient. Another important variation is the fact that radiography produces one projection and you are done, you get your image. In X-ray CT, we produce many of those projections, projection 1 and 2 and 3 and so on. And in fact, if you really look at some of the details in X-ray CT, you will find that the X-ray tube will have to rotate, producing so many of those projections similar to which we have in there, over a short window of time as well. This one takes here about like 0.3 of a second, let's say. So nowadays, technology, when we do cardiac CT, it would take about 0.3 of a second to do the whole thing over the heart for cardiac studies. So with this, in this case, you need to have some kind of a robust system that will allow for producing not one projection, but two, not two, but three, and not three, but 300, 400, 700 in one full rotation to produce either a single slice or multiple slices over a small volume of tissue. So that is really the important thing about comparison between CT and radiography. In CT radiography, we could use films and CR and DR. Those are types of receivers. In CT, clearly, we most of the time use, or all the time use, detectors, which are made of solid state material, and they have a higher detection efficiency, especially the fact that they are small in size. And nowadays technology, we have truly to do our CT scans pretty fast. And because of this, we invented different acquisition methods, axial techniques and helical techniques and fusion techniques and all that. All those come to help us expedite and do fast scans. This is, for instance, an example of a helical CT scan where the patient actually literally moves through the gantry of the system, and the X-ray tube and the detectors are rotating around the patient. Not as fast as you can see in here, but basically it is to illustrate the idea that those images can in fact be obtained using short exposure times. This here then the end result. So this is a radiographic system, just in case you did not see one of them. This is the X-ray tube, and that's what we use for chest radiographs, right? And that is a table in there. You can produce images on that receiver in here, or on the receiver if it happened to be inside the table in there. And similarly, CT, as you can see, this is an actual CT scanner. It's larger. It has a donut-shaped gantry. You have it there. It has a table in here, and you can do both axial and helical scans. One last thing I want to mention in here about information that we are obtaining. Every line of information in here is going to produce a dot, if you like, on the radiograph. That dot is a reflection of the amount of radiation reaching the detector. And that amount of radiation will vary depending on the thickness of the anatomy as well as the composition of that anatomy, what is inside that patient. And because of this, you're going to produce, if you like a map of distributed X-ray photons over the receiver. If all areas on the receiver show the same amount of radiation, you will get no image. It is the fact that we produce differential distribution of radiation coming from the patient related to differential attenuation governed by this relationship. It is the attenuation of the beam due to the thickness as well as tissue composition. We bundle tissue composition and beam energy in this particular factor in here. So variation in patient thickness and patient composition will bring us some kind of heterogeneity and in the distribution of the radiation, and that will end up with producing the contrast we are looking for. This is the end result of a radiograph. It's just a radiograph in here, and as you can see, 3D, everything superimposed in a 2D image there, and there we have clearly a more contrasty image in the brain, demonstrating a two-dimensional image, or almost two-dimensional image, because their thickness of about 1 millimeter or 1.5 millimeter or 3 millimeters cannot be ignored. And actually, this is one reason that our resolution in CT is inferior to a resolution in, I'm talking about spatial resolution in here, is inferior to the resolution in, let's say, chest radiography or in general radiography. One of those reasons is the fact that we have that particular condition. So let's now look at another aspect and see where does a dual energy fit in this world of X-ray CT. When we do CT scans, we start actually putting the patient on the table in there and do a scout view or a scanogram. The idea of this is just really to know where we want to start and where we want to finish. If I do a liver scan, for instance, a liver CT, I'd like to start somewhere around in here and somewhere in there. So that's the beginning, that's the end, done using that kind of scout view. It's more or less like a radiograph, basically. And from that point on, you can do your axials, you can do your helicals, you can do your cone beam. A list of possibilities are available to you. The most common acquisitions done in CT are axial and helical scans, more of the helical scans because they are faster and they can also cover larger amount of tissue per rotation. So you can actually start and end quickly, especially if you are concerned about breathing the patient, because that introduces motion. So you can actually ask the patient to hold their breath, and within 5 seconds, the whole patient is covered from, let's see, from the top all the way down to probably at the liver level, also something that we have in there. So one of the important aspects of doing CT is to understand how each one of those actually works. So if you want to be a diagnostic physicist, you really in CT, and to understand how CT works, you really have to understand how you control the parameters that will produce good cardiac study, cardiac CT study, good CT angiogram study, and so on. So as you can see, dual energy CT is just really one of those variations available to us in the field of clinical applications of CT. And in here, the concept is that all modalities in here, all variations in here, use a CT scanner with single energy. That's to say, you select one KVP and you do it. You do your helicals, you do your axials, cardiac, whatever. Just 120 kVp or 120 kVp, and that's it. But when it comes to dual energy CT, clearly, as the word implies, and here you need to have two energies, and from there you produce two attenuation maps to end up with producing your images. Now, just before going to this, I showed you before, is what is dual energy? This is defined what is dual energy in very simple terms, basically. It is acquisition of two CT data sets from two different X-ray spectra. Two spectra is going to be produced in there. And from there, clearly, going to end up with producing at two different voltages, which means different energies, for instance, in here. That will allow us, in this case, to create two different attenuation coefficient maps. That's where we work. Well, that's where we start working and take information from attenuation coefficient map obtained at 80 kDp, and the other one obtained, let's say, at 140 kDp. Mathematical algorithms will allow us to figure out what's really happening at a particular pixel or voxel, if you like, in terms of tissue composition. So identifying of tissue, type of material in that particular pixel will be obtained using this particular concept. So with that, in this case, it should be possible to obtain material-specific images. I must say here, I mean, it should really be important to remember that long before dual energy CTs, people actually did dual energy in digital radiography, or even older days of radiography. It's not really that difficult to produce two images at two different energies of the same anatomy. So here is the chest radiograph. You can actually produce 120 kVp and another image, if you like, at a different energy. Use different configurations. It doesn't matter how you produce it. And you end up, in this case, with maps demonstrating information coming from this here, a single energy, 120 kVp, single energy image. And as you can see, there is a lot of soft tissue in here, lung tissue, bone, ribs, so much information in there. And is it possible in this case that you say to yourself, well, okay, is it possible to remove bone from this image? Yes, it is. And that dual energy system will allow you to get rid of, if you like, the bone component on those pixels, or pixels that contain significant amount of bone, or the other way around. You can actually say to yourself, how about if I get rid of the soft tissue in this image, and in this case you produce an image that demonstrates mainly bone, and soft tissue is going to be more or less removed. So this is actually a better illustration of a concept where soft tissue, there is a lung nodule in there, and that soft tissue, when it was demonstrated, did not show that lung nodule clearly, and it turned to be that that lung nodule was actually calcified. It appeared like bone. So when we removed bone, it went away with it. So of course they will be saying, what happened? Am I supposed not to see that thing there? But clearly it appeared when you just really looked at the bone image rather than mixing it with the soft tissue image. Okay, so why we want to do dual energy CT? And clinical applications help us actually to look and go beyond morphology, anatomy if you like, and structure, and obtain material-specific images. And it's not only just colors that we are going to get in here, as you can see there, but quantification of iodine content. We can actually produce images. Iodine is a contrast media inject in the patient to show the difference between tissues that do not have sufficient contrast and the surrounding blood vessels, for instance. The characteristics of blood, the blood vessel, and the tissue surrounding blood vessel is the same. They attenuate by the same percentages. So if I want to see the blood vessel, what do? I inject it with contrast media, so it will shine. Why? Because it has high absorption coefficient. So iodine quantification is possible. Another applications to use mass characterization, can tell what kind of mass to some extent, and clinicians or radiologists will become actually kind of more familiar with this. A function, artifacts reduction, like metal artifacts in the patient, dental fillings and prostheses, all these things can in fact be negotiated using this particular technique. And of course improved visualization. Remove bone from this angiogram in here, or remove soft tissue and keep bone is something that you can also achieve. Now again, let me go back to the basics for the sake of who did not have probably better exposure to how we produce X-rays. X-ray tubes produce X-rays, and they are energized at different kV settings. You energize your X-ray at 60 kV. This happened to be a tungsten target, and this is the spectrum you get. And I really like to pay attention to the word spectrum. It is not one single energy that comes from the X-ray tube. It is a range of energies. And that range of energy becomes actually more when you increase the kV in here, and there, and there. So higher kVPs are associated with producing more radiation from that X-ray tube, and also high energy radiations. So these are different spectra that are associated with different kVP settings. Every spectrum you see in here can be characterized by looking at 3 parameters. One of those parameters is the minimum energy in the beam, in the spectrum in here. And as you can see, despite the fact that they are produced at different kV settings, they all have the same minimum energy. So how come? Why is that? Well, it's simply because the filter material used to remove soft radiation is efficient against all soft radiations below this energy. All of them have that energy, and therefore it will look as, of course, they have the same minimum energy. However, the maximum energy in the beam is going to be defined by the kV setting. You are not going to get more than 120 keV if you are operating at 120 kVp. And so with that said, in this case, tissue attenuation is going to be something that we're going to be addressing, and we're going to say that tissue attenuation is energy dependent. Whether I'm at 40 keV in here or at 70 keV there, and so on, I'm actually going to get different tissue attenuation coefficients, different tissue attenuation values. Another thing is the concept of effective energy. So if I want to have some kind of a signature for this spectrum, because dual energy means what? You have to have 2 energies, not a spectrum. I can't work with a spectrum to produce my maps. I need each one of those spectra, which you see in here, to be identified or to be assigned an effective energy. That's, if you like, the fingerprint for that particular spectrum. So we go from, in this case, this wide range of energies into an effective energy. And the effective energy can be illustrated in here. This is an 80 kVp beam there. It's basically minimum energy, maximum energy, and the effective energy is something that one can actually calculate. It's not really a big deal. You look how many photons are there at this particular energy, how many photons at that, and add them together, divide by the total number of photons, you get your effective energy. So the fingerprint in this case, or the signature of this beam coming from the X-ray tube, has an effective energy of 40 keV, and that's what I'll be using for dual energy CTs, employing that spectrum. This is another spectrum coming using 140 kVp, as you can see. The effective energy in that beam will be higher. Why? Because in a 140 kVp spectrum, you have more energetic radiation. So it will push the effective energy into higher levels. And this is also a variation of this 140 kV. Right? By adding filters, I can actually significantly reduce that soft radiation. If I go back in here, this beam contains a lot of soft radiation, that 140, that's soft radiation in there. But if I go into removing that soft radiation using some kind of additional filter, we call it specific photon shield filter. Basically, it is an additional filter in there that will help reduce that energy, and therefore the effective energy will move to the right, as you can see. So it's important in this case to remember that what we work with when it comes to CT is that particular energy. In fact, the attenuation, characterization of the attenuation process is associated with a particular energy. I can actually take the whole spectrum and try to look at attenuation at every single energy in the spectrum, but I'm going to look at that particular energy. The X-ray tube produces that spectrum, and that spectrum is going to be called the primary beam. When it hits the patient, it gets attenuated. Attenuation means two things. One thing is part of the beam is going to be absorbed. You see that beam totally absorbed, gone. No radiation is there. And part of the beam will be eliminated, if you like, by scattered radiation, by scattering. Now, eliminated does not necessarily mean, it could be actually direction and out of the, doesn't reach the patient, that's a possibility. But scattered radiation reaching an area on the receiver that does not reflect that particular anatomy is useless information. Because I cannot correlate this anatomy to that event occurring in there. So to me, it's actually, if you like, background noise. Or if you are using a film, it's actually going to increase background density, and contrast resolution is going to suffer. Scattering is not our friend in diagnostic radiology. It causes us a lot of problems. So the combination of those two parameters, absorption of radiation and scattering, brings about that kind of reduction in the primary intensity. A quick look at what is photoelectric effect. Photoelectric effect, or the absorption effect, is interaction of incident X-rays, as you can see in here, with inner shell electrons of an atom. This is an iodine atom, I think, yeah? And when 100 keV photon interacts with the inner shell electron, it gives it all of its energy. And the word all should be emphasized. So the photon disappears. So when you say this is photoelectric, you know for sure that that photon is gone. Its energy will be used to overcome the binding energy of this electron in the K-shell in here, which will be ejected with the difference between the binding energy and the incident photon energy. And that process leads to other things, production of characteristic radiation, which is beyond of our discussion at this point in here. So that's one way for radiation to be removed from the beam. This particular absorption mechanism is prominent at low energy radiations. The lower is the energy of the beam, the higher is the possibility for absorption. And clearly, that's intuitive even. And also it is strong, it's going to be higher at high atomic number materials. If you look at soft tissue and calcium, where you expect at a specific energy, where you expect to get more absorption? In soft tissue or in calcium, in bones? Clearly in bones, because they have higher atomic number materials. Another thing is to look at Compton scattering. Compton scattering occurs with higher energies. When the beam energy is higher, chances are it will not really reach, if you like, to interact with the inner shell electrons of an atom. It would rather interact with the outer shell electrons of an atom. And those outer shell electrons are usually loose, right? They don't have binding energy to hold them in place. So it will look as if the incident radiation comes like a turbulent, and then it will just they feel each other. The X-ray beam scatters, and the electron will be ejected. But there will be exchange of energy though. The incident photon scatters and loses energy that is given to that electron. So the process ends up with this photon changing direction. And in this case, it will not go to the same anatomy where we expect it to appear. Combined together, now put these two together, I'll get to something called the attenuation coefficient, which is actually going to be related to those two parameters, absorption of the beam and scattering of the beam. That yields the fractional change in intensity. Primary beam gets reduced. That fractional change per unit of length will be the linear attenuation coefficient. Per unit of mass will be the mass attenuation coefficient. And that attenuation coefficient is energy independent material. Why? The photoelectric effect is energy and material dependent. So Compton scattering, both of them are, so the attenuation coefficient will be also the same. If one is to look here at the behavior of the attenuation coefficient, photoelectric effect in here, and Compton scattering, there is a third one called O'Reilly scattering. It's not really important a lot in diagnostic radiology. It usually occurs at very low energies, relatively low energies, so it makes bit contribution but not significant. You will find that photoelectric effect drops down with energy. Compton scattering actually picks up with energy slightly, and it occurs, as we said, at higher energies. The combined effect of those two parameters shows us that the attenuation coefficient in here drops down with energy. Doesn't matter what material you're talking about, higher energies, the beam will pass through. It's not going to have time to wander around and make interactions. So it is the attenuation coefficient that is of more important to our work in X-ray CT. Why? Because every time we look at an image, radiologist looks at an image, they really look at distribution of, if you like, shades of gray, wide shades of gray. But those shades of gray inside of the pixels come from distribution of CT numbers. See the CT number in here? The CT number will be translated into, let's say, a shade of gray. There are ways for doing that. But where the CT number comes from to start with, when Godfrey Hansfeld introduced the concept of CT, he wanted to have a metric for characterizing the contents of each pixel. Pixel information content is going to be characterized by looking at that CT number. But of course he knows that the CT number you have in there, or the shade of gray you have in there, is related to the attenuation characteristics of that material in that pixel. So he said, here is my suggestion, and it is really what he did, said, let's take the attenuation coefficient. The CT number would be defined according to him as, it is the attenuation coefficient of the material in that pixel minus the attenuation coefficient of a reference material, and he chose water to be that reference material, divided by the attenuation coefficient of water. And that's why if that pixel happened to have water in it, what would be the CT number for that water? 0. Because your material will be water. Water minus water is 0, and that you get a CT number of 0 for water. Now, when he looked at the attenuation coefficient difference between the highest material in the body, let's say bone, right, and that of soft tissue or water, he found that the difference between here and there is very small. So he wanted to amplify it. So initially he put a figure of 500, which was referred to here as Hansfeld constant. And if you look at the literature, the old literature, you find that CT bone is 500. Of course, he changed that. Not the people in the field changed that into 1,000 to scale it even more. So the CT number we are looking at is in fact related to the attenuation characteristics, and in fact it comes from a voxel of tissue. What is the difference between a pixel and a voxel? A pixel is what you see in the image. So the image matrix is made of picture elements, pixels. But what is a voxel? A voxel is a volume of tissue, has certain amount of information, and it has 3 dimensions. 2 dimensions are the image dimensions. I see this one in that direction in there. But the 3rd dimension is the slice thickness. And clearly, as you can see in here, the more slice thickness you have, the more averaging you're going to have in that pixel, and the more degradation of resolution you are going to obtain. So let's look at now having all this understanding, I hope that you have some kind of a common understanding of what we are talking about in here. Let's look here at the question of dual energy CT. Here is a phantom that contains inside of it bone and iodine, and in fact also fat and plastic on the other side there. So we expose this phantom to 80 kV ppm CT, produce an image of this phantom at 80 kV, 100 kV, 120, and 140. If you look here at iodine and bone, what you will find, because they have high atomic number material and it is low energy, what is going to happen? You're going to have actually strong or high attenuation coefficient in iodine and bone. But once you increase the kV from 80 to 100 kV, to 120, to 140, you're going to find that the CT number for iodine and bone will drop. Go to the math, it's the concept which I explained before. So higher CT values are going to be seen at 80 kVp for iodine, bone, metal objects, for instance, prostheses and all that. But if you look at fat and plastic in here will demonstrate actually the exact opposite. You're going to find that the CT number for fat and plastic and for also urine is going to be higher, at higher energies. And then it actually goes backward in the opposite direction. So at high energies, you're going to find that fat demonstrates or shows higher CT number. Why? Because Compton scattering at higher energies, what is the dominant interaction? Compton scattering. And Compton scattering is not atomic number dependent. It actually depends on electron density. You remember it's the outer shell electrons that matter there? And therefore, tissues that have more electrons per gram are going actually to have more attenuation. And why fat should have more electrons per gram? Because of hydrogen. Hydrogen has what? One proton, you don't have a neutron, so you can squeeze a lot of hydrogen in a small mass. It's basically Avogadro's number. I mean, that's what the number is. So if you look then at the combination of those, you're going to end up with showing that there are variations in the CT number from low energy to higher energies. And if you look at the other materials or tissues like water, soft tissue, and blood, they do not change significantly. They more or less produce the same values. Why I'm saying this? Because I want to tell you that when we do dual energy CT, we count on looking at iodine and bone and metal objects and iron in blood, like in hemorrhage, and fat and things like this. But we don't really care much about, let's say, soft tissue, or rely on getting dual energy from basically soft tissues. They don't demonstrate a lot of changes in the process. So here is our lookup table, if you like, the graph which we use to obtain to look at variation of CT number for different tissues or different materials. This is what we obtained at 80 kVp. This is an 80 kVp for this phantom in here with those materials inside of there. And this is what we obtained at 140 kVp. So if I look here at, let's say, water, whether it is 180 or 140 kV is going to return 0. That's the CT number, 0 Hansfield units. If you look here at the blood, slightly higher than that. And but again, at 80 or 140, they are too close. It's the same, always the same value. Look at iodine, for instance. At 80 kVp, you produce a high CT number, and it is naturally as high when you do it at 140 kVp. And so on, of course, you're going to look at bone. So a map like this tells us that the fact that we have different KVP settings help us separate one material from the other, because those materials demonstrate different behavior at different KVP settings. Can we utilize that for something good? We can actually look at examples where this technique can help us separate materials at the same position in an anatomy. Take an example for a given single energy X-ray source. It may be difficult to distinguish contrast from plaques. Plaque buildup of that material in the blood vessels there. And a lot of times it could be possible that the plaque material mimics the concentration of contrast material, and you can't really separate one from the other. So you look at it, the blood vessel is filled with contrast material, the plaque is there, and you say, well, does it really look like black, or this contrast is in there? In a single energy setting, it will be hard to separate the two. But if you do dual energy, you can actually have two KV settings, and from there, you can characterize those two entities. And the same thing when it comes here calcium that can also mimic contrast material. So if they happen to appear in a single image in the same location, it will be hard to separate one from the other. So what do? This is what we get here at 80 kVp. Bone shows us a CT number of 350 Hansfield units. And you know who else can show us that? Iodine. Iodine with a concentration exactly of 8.8 milligram per milliliter is going to produce the same value. And you may say, how do you get this number? Why 8.8 milligram per milliliter? Because when contrast goes in tissue, you're going to find some of those pixels containing contrast values or concentrations that can be in that particular range. So if that happens in this case, you're going to end up with showing that contrast, or rather that contrast appearing, and it will look like exactly like bone. The same thing, as a matter of fact, this is just a summary of the two things that you have in here. Bone at 80 kVp produces 350 Hounsfield units, so as iodine with that concentration. Now, if you do the same thing at 140 kVp for bone and iodine contrast. Now, bone is going to, now at 140 is going to produce a lower value, 220, and iodine contrast at that energy is going to produce 220 as well. So now here is my table. This is going to appear in the same location as well. I'm going to separate from one from the other. I'm clearly going to produce some kind of a graph, a scatter plot, which shows the values I have obtained. Those are the values I have to obtain for bone at these two energy settings, and for iodine at these two energy settings in there. At different concentrations, I'm getting those values there. Put all those on the graph. This is I'm going to get from bone, 80 kVp, 350, and 140 kVp, about 220. This is what I'm going to get from the iodine 8.8 milligram per milliliter. This I'm going to get here from iodine 10.3 milligrams. Clearly, I was able to separate them using this particular configuration. So this is one way of looking at it. In fact, this helps us also to say, forget about bone for a minute, take that bone out of the picture and say, can I not, in this case, if I have a correlation between the CT number or Hounsfield number variation here and iodine concentration, can I not produce some kind of a relationship between this is a value, this value here is 0, that means there is no contrast in the material in there, and the contrast material content, which basically says in here that different concentrations of iodine can in fact produce different Hounsfield units at different kV settings. So I'll go backwards in this case. If I produce an image and the pixel value for that image at 80 kVp is that much, and at 120 kVp is that much, I can tell exactly what is the iodine content. The concentration of iodine can in fact be identified. So we use this as some kind of a measure of iodine concentration as function of distance from clearly the 0 value, which we have. 0 means that we don't have iodine contrast in that particular picture. So here is the situation where we have studies like when you do liver CT, and you put contrast in liver CT. So the three parameters or three materials that are of interest to us going to be liver tissue, fat in the liver, as well as contrast media. So here is a 3-material decomposition of liver, fat, and iodine in that setting. This is what I'm going to get for fat. Fat will produce a CT number at 80 kVp and at 140 kVp. They are close. They are slightly higher in case of 140 kVp. This is what fat plus iodine pixels look like. So if you have a pixel that has fat in it and you keep adding contrast with different concentrations, what's going to happen? The CT number will go to increase. So this is a reflection of the iodine content in that fat pixel. What about liver tissue? Here is liver tissue. This is the CT number for Hounsfield number for the liver at 80 kVp and for the liver at about 140 kV voltage. So now I'm actually going to add contrast to the liver. Here is liver plus iodine. The graph shows me that more iodine I add to the liver, the higher the numbers are going to be. But not only we have fat and iodine in the liver, and just liver and iodine, but we also have fat and liver. As a matter of fact, if the liver happen to have some fatty variation, which they do, don't they? I mean, fat is part of liver. So what are you going to have? A fatty liver will retain a value like this. Why? Because remember that fat has a CT number which is below 0, negative. So when you add fat to the liver is about 50 or so, you add fat to the liver, it will bring the number down. In fact, the more fat you have in the liver, in there, the lower this number becomes. If the liver is 100% fat, this is what you are going to get. So from this, actually, I can produce what we call the fat liver CT numbers variation with different concentrations of fat. This is 100% fat, and of course going up here towards 100% liver, little fat. So then when you do a CT scan, all your pixels are in fact going to be squeezed between the fat plus iodine, or liver plus iodine, or fat and liver. And if I happen to have a pixel which looks or appears there, so I go to my image there, or the system goes to the image and says, tell me how much iodine that particular pixel have. Well, simply, this pixel is neither liver plus iodine, it's neither fat, it's somewhere in between. So it has these three compositions, and from there I can actually say, if I draw a line parallel to this line in here or parallel to that line in there, I'm actually going to see that the fact that this pixel is at that level because of the iodine content. If there is no iodine in this pixel, what is going to appear? It's going to appear along this line because it's only fat and liver. But the fact that there is some iodine contrast in it brings it to that level. And the higher is the iodine content in that pixel, the higher that number is, of course, going to be. So if you then pick a pixel and you know at 80 kVp, it gives you this Hounsfield number. At, let's say, at 140 kVp, it gives you that number. You put it there, draw a line, and you're going to get an idea about the pixel iodine content. You do it for one pixel, you can do it for millions of those pixels in that particular image, or whatever is the number of pixels that are appearing in there. So you can actually produce some kind of a map of iodine content in that particular image, which is in itself useful to us, and I'll show you how useful it's actually going to be. One of the applications of this particular lookup table, that will become a lookup table. It will go just into the scanner system in there, using the algorithms for that, and end up with appearing like a lookup table. So one of the advantages of this is the fact that this is a true image of the liver. It's produced from single kV setting, right? This image was obtained using dual energy with contrast media. It's the same liver, the same patient basically, but this was done with contrast media, dual energy. So if I allow for the system to identify every single pixel in the liver in here and remove iodine content from it, because I know how much iodine is there in every single pixel, what am I going to get? I'm actually going to get an image of the liver without contrast. And actually it will look like this. So this image is actually more or less the same image. Clearly is not as contrasty as this image in here. There are issues related to this. But basically, from this contrast image, I can produce something called virtual non-contrast image, VNC. Very common to us in dual energy CT that we produce VNCs. Basically, what is the advantage of this? Why you want to do this? In liver CT scans usually, on many other scans, our scans are done using with and without contrast. If you live in that environment, the referring physician will be saying CT scan of the liver, with and without. They do the scan first with, without, and then you do it with. If I can produce my without contrast image from here, do I need to scan the patient twice? No. That's exactly the advantage of it. With VNCs that we are seeing in here, I do only one CT scan with contrast media, use the algorithms available to remove contrast, and from there it should be possible to produce values which are close to this. And you may ask me, how close is the CT number here to the CT number in there? Let's say that the CT number in here is about 60. CT number in there could possibly be about 60 plus minus 4, which is fine for clinical purposes. It is fine. I mean, the radiologists agree if the variation or the difference between actual and virtual is in that range for the liver, we are happy with that, and in this case, we don't have to expose our patients to high energies. Another application of dual energy CT is the fact that we can, in fact, combine images obtained at different kV settings. Here is an image obtained of the liver again, image obtained at 80 kVp of the liver, of the abdomen liver level, kidney levels in here. What is good about low kV images in diagnostic radiology? They produce good contrast resolution, thanks to the photoelectric effect. That's the dominant interaction at low KVPs. And therefore, you're going to end up with showing good contrast resolution. But unfortunately, they can be noisy. See the noise texture in here? Why noisy? Because 80 kVp does not have as much radiation. Radiation output of the tube is not as much as, of course, 140 kV. And therefore, an image at 80 kVp has good contrast resolution, but relatively high noise level. But if you do the same image at 140 kV with thin filter in here, then in this case, you get lower contrast, you know that, but at the same time, better noise properties, 140 kV, too much radiation. So the question is in here, can I do something about this? Like, for instance, I have good contrast in here, it's a little noisy. I have here, not as much contrast, but it has better signal-to-noise ratio, better noise level. So how about producing a blend? I mix them together. I say, how about if I take, let's say, 40% of this image, that's to say, I come to a pixel in here, this pixel value there, I take 40% of that pixel value, and then I go to that image, the same pixel, I take 60% of that pixel value and put it in that location, which is, of course, the same location as those images. That kind of blending of images or mixing of images help me to produce an image that has much better contrast resolution compared to this, not as good as that, but it is compared to this one in here, and also it has lower noise level compared to what I have in there. In fact, if you look at the image obtained in here, this is exactly similar to an image obtained at 120 kVp. So this, take 0.4 of this, 0.6 of that, you produce an image, a CT image, as if it was produced at 120 kVp. Now you play with that. Radiologists sit there and say, okay, I want to produce 0.3, 0.6, or 0.7, 0.1, 0.9, meaning that I will accept more noise or less noise. I want more contrast or less contrast, and so on. And in time, they develop some kind of expertise and knowledge and even protocols saying that for this particular type of disease, my blend will be 0.3, 0.7, and so on. There's another way of mixing. What I talked about in here is simply linear mixing, percentage, 30, 40, 70, and so on. There is also another way of optimization of my contrast using the dual energy. I have the information from the 80 kVp as well as from that guy in there. And of course, as I said, I produce my mixed image at 0.4% or 40% in here. But then I can actually tell the system, look, go back to those pixels in there and get me in this image and that image. This is pixel, let's say 300. Go to pixel 300 in here and go to pixel 300 there. Which one has better signal-to-noise ratio? If it is from this image, good, go and put it there. Take it from here, take the information from here, there. So it is not, I mean, when you do all your KV at 80 kVs and 100 kVs, it is not that all signals in here are inferior to all signals there. Some signal values are going to be good in here, or pixel values are going to be good. And therefore, you start to tell the system, get me the best out of this in terms of signal-to-noise ratio, get me the best of that, and assign whatever you get to the new image. That's what we do, something called optimum contrast image. And as you can see in here, this is the image obtained using this ratio, but this is the image obtained after contrast optimization. Clearly, it is more contrasty. That is another application that we can actually use. Another application is also the use of what we call virtual monoenergetic images. Remember again, our CT scans do not produce monoenergetic spectrum. It's actually a spectrum. But then one can actually say, if you can actually have a map of the attenuation coefficient from this 80 kVp and that 140 kVp, that will help you, in this case, identify what is in that pixel, right? At the 80 kV and 120 kVp, the purpose of that is to do material decomposition and identify what is exactly in that particular pixel. So if I know what material is there in that particular pixel, I can go to lookup tables and say, what would be the attenuation coefficient of this material at, let's say, 40 keV? And there are, the National Institute of Standards have materials, energy, and attenuation coefficient. Tell me the material, tell me the energy, I'll tell you what is the attenuation coefficient, and from there you calculate your CT number. So in this case, what I could actually do, depending on this information I'm getting from there, knowing what is the tissue composition in every one of those pixels, I can produce an image at 40 keV, which means, in this case, that the tissue composition in here will look certain way if it were obtained at 40 keV. Where I get those numbers from again, look up tables, and they are published. And I can do the same thing for 70 keV in here, and the other number is 100 keV, and so on. So what is the advantage of this? Clearly going from an effective energy of 40 keV to, let's say, 120 keV, whatever is that number, 150 keV, demonstrates what? See the contrast in here is actually going down and down and down. So the effective energy, the fact I can achieve higher effective energies, brings the attenuation coefficient lower and lower, and I produce an image with relatively lower attenuation coefficient. So this enhancement I see in here is going to change clearly significantly, producing lower contrast. What is the advantage of that? Here, you remember the problem with metal artifacts in CT? A lot of times you just throw the image and say, I don't want this image. I don't like it because the patient has a prosthesis, they have a stent in the heart, they have some metal object that makes your images streaky. They produce significant amount of artifacts, something that we have in here. So if I do dual energy in this case, this metal, when I go into low energy and high energy, 80 and 140 keV, I produce the two maps. And I identify where are the pixels that contain metal. And then I go to the lookup table and I say, I know that is this pixel contains that particular type of material. What is the attenuation coefficient of that pixel at, let's say, 190 keV even? And from there, I can suppress or significantly remove the effect of those artifacts that you're seeing in there. So this is 120 keV monoenergetic beam, and from there you can actually go wide with producing wide range of energies. So that's another important application that we have in there. For dual energy CT to be successful, you should really have sufficient separation between the maps, 80 kVp map and 140 kVp map. Real life radiology tells us that they actually came from spectra. 80 kVp is a spectrum, so as that one is a spectrum. Reality tells us that there may be actually some kind of overlapping in the spectra between those two situations. So this is 100 and 140 kV settings. That's the overlap you see in there. Overlap means what? If you see a pixel seen by 100 and 140, you can't really swear that this pixel attenuation coefficient is truly the 100 or the 140. There is an overlap. Its uncertainty is going to be there. That uncertainty will be reduced when you have more separation, 90, 150, or 80, 150. That will provide for more separation of the spectra. There is one unique spectrum for the 90, and then the 150, there is a little overlap in there, which is going to introduce that kind of uncertainty. How you achieve this? Basically, filters. This is an 80 kVp spectrum. It doesn't show the whole blue thing in there. This is 140 kVp spectra. And this here, the third one in there, is the 140 kVp with additional filter. We put a 10 filter in there, which will remove significant amount of soft radiation. If you use 80 and 100, there is a lot of overlap between them. But if you use 80 and 140, there is less overlap. And with that, there is a situation in here where if the spectra are too close to each other, and I'm really looking at, let's say, bone marrow, this is an angiogram, right? Angio. And in angiography, you have blood vessels, and you have a lot of bone in the neck, for instance, surrounding the blood vessels. And we have the possibility or the chance of removing bone from the images we obtain. However, there may be residual bone that can mimic contrast media in the blood vessel. It will look like bone. So here's the situation. When we produce the marrow bone graph or line at different kVp settings in here, and compare that to blood and iodine, the blood vessel in here contains iodine in it, you're going to actually to see some kind of a separation line between them. you're going to find that there are pixels which are, this is the separation line, and by the way, the separation line is an experimental line. They figure it out with time and do a lot of work until they say, well, here's my separation line going to be. So all pixels that are in this part of the spectrum are going to be labeled as iodine pixels. And the ones which are further down in here are going to be labeled as bone pixels. So the green ones are bone pixels. But look at this pixel in here. It's actually appearing, that bone pixel is appearing where? In the iodine family. So when I have an image like this guy in here, this is an angiogram there, and showing bone and blood vessels in there. What you're actually going to see that when I remove bone, now I'm going to get rid of bone from that image, right? So here's bone gone, and I'm actually going to see a problem. And that problem is, look at that pixel in there. This is a blood vessel that's supposed to contain what? Contrast media. But when I removed bone, that particular pixel was misinterpreted. It was actually seen as bone, and it actually removed it. So what the radiologist is going to say, hey, there is a stenosis there. Let me take the patient to do an angiogram on the patient based on this false information. And you know how invasive angiograms are. Actual angiograms, not that virtual. So with that, in this case, what will happen now if I allow for more separation? See, this is what we have before the separation. Now I have more separation by employing more filters. You're actually going to get clear delineation between what is considered to be iodine pixels and others that contain bone inside them. And I produce a nice image here that contains really no bone whatsoever. So with that said, in this case, I'm going to come to the last part of the discussion, not too long, and that is how we produce those dual energies. I mean, you say that X-ray scanner can go to 80 and 100 kVps or 140 kVps. How you manage that? Actually, different vendors approach it different ways. A vendor means the company, you know, those produce those machines in there. As a matter of fact, almost all vendors produce what we call the single source dual energy system, which basically means that you use only one X-ray tube in here, and you just switch between low energy and high energy. You know how you do this varies, but there's only one vendor which uses dual source. Dual source means two X-ray tubes, one X-ray tube and detector in here, another in there, and they rotate at the same time to produce your final images. So let's look here at the possibilities. Fast KVP switching is one possibility. Dual energy spiral is another possibility. We have twin beams. We have also dual layer detector. And also the last thing is dual rotation. So here's a sample of a dual source energy. Two sources producing two maps of the same anatomy at the same time, simultaneously. That's really crucial. And with that, in this case, you're going to produce simultaneous acquisition, independent MA for both high and low KVs. With this image in here, if this happened to be the high KV, I will use lower MAs. If this happened to be the low KV, I use higher MAs to compensate for, of course, the loss of photons. And that helps me reduce dose. If I go to lower KV, or rather, when I go to higher KVs, I can lower the MA. That helps me reduce the patient dose. So this is another technique which uses two consecutive CT scans at two different KV settings. Basically, I want to do level scan. All right, put the patient there. Scan the patient at, let's say, 80 kVp. Repeat the same scan at 140 kVp. And then take the information to your scanner. The delay is about 4 seconds. Patients move even within 1 second, let alone 4 seconds. So the image obtained at 80 kVp may not really match exactly the image obtained at 140 kVp. And in this case, you run into problems of mismatching between your images. They're supposed to be the exact anatomy. And that creates some kind of problems as well. There is another technique in here which uses what we call a split beam. Instead of using two different KV settings, you use one KVP, like 120 kVp. And at the filter level, we actually put a filter material, split filter, which has the tin and aluminum and gold and aluminum. And that produces two spectra. Simple as that. So the effective energy here is going to be different from the effective energy there, and you will end up in this case with having two beams. The beam is actually going to be split into two halves, and one of them will be producing higher energy compared to the other one. That is another way of producing it. One particular vendor, one company, said that if I want to produce images, I have two sets of detectors in here, this set and that set. And I hit it by 120 kVp, let's say. The beam that produces this image, part of it is actually going to go to the back there and produce the next image. And that detector system is going to filter the beam. So the effective energy of the beam here is going to be different from the effective energy of the beam in there. And that in itself is two energy settings as well. How good is that? I'm not sure. I mean, it has some issues and problems. But again, this is beyond the discussion. We can talk about that some other time. There is one vendor also uses what is called the fast KV switching, which means while the X-ray tube is rotating around the patient, we said, what does it do? It produces projections. Projection 1, 2, 3, 4, 5. So what it does, it says, well, okay, projection number 1, 140 kV. It doesn't really go to as high as 140. Let's say 120 kV. Projection number 2, 90. Projection number 3, 120, 90, 140, and so on. So with that, in this case, you produce two maps, and one is going to be with the 120 kV, the high energy, and the other one is going to be at the lower energy. And again, there is a big, big problem associated with this. When you go to lower energy kV settings, you don't have sufficient radiation. What do? You have to increase the milliampere. Now, switching the kVp from 120 to 90 kVp may not be a big deal. But switching the milliampere from low milliampere to high milliampere over a fraction of a second, that is a big deal. And that's why they got problems. They solved it, I must say. I know that they solved that problem, but it's still one of the limitations of this particular technique. A quick comparison between all those modalities, fast KV switching versus, let's say, dual layer technique versus dual source geometry. Advantages, the blue ones are advantages, the dark ones are limitations of all those modalities. So if this is recorded, and I'm not going to go through the details of it, you might actually go back to it, and if you are interested in knowing the differences between one and the other, you might actually consult this particular slide in there. One last thing is dose. Some people think because we're doing dual energy CT, we are increasing the dose to the patient significantly. The fact of the matter, this is actually one of the papers produced in 2010, addresses this particular issue and concluded that the CT can be performed routinely in dual energy mode without additional dose or compromise in image quality. That's actually been verified, although this is an old paper, about 6-7 years old, that's actually been verified. And in fact, with nowadays technology, it should be possible really to produce images that have CTDI volumes from dual energy as low as about that much from this particular scan in there, and which is the single energy system, and from dual energy system is even slightly lower. So that's really something that is achievable. But that's really an area, what if you are interested in dual energy CT, you might actually explore yourselves. And put a phantom in there, put chambers there, try to make measurements, play with it and see what you get from your scanners if you have the potential or capability of doing that. In summary here, that dual energy CT, when two different energies are applied, the distinct signature of each element allows material decomposition in each voxel, and that is the basis for for dual energy CT. Not all elements are good candidates for dual energy CT. Some of them are better than others. Some of them are useless at all. High spectral separation allows for more accurate material decomposition, and that's why you need to have those systems that are capable of producing two energies, one high and one low. Different X-ray tube voltage configurations are used with advantages and limitations, so we are comparing the ones in there. And last is that dose neutrality claims with dual energy needs further verification. Neutrality means that you will get more or less the same dose, whether you're doing single energy or dual energy. That's something that still needs to be looked upon and being verified more. And with that, I'll conclude, and thank you for listening.
Well, thank you very much
Sure.
for this nice talk. It's time for questions. If someone feels that needs help to translate to English, there is no problem. The point is that questions are welcome at this moment.
I have a question really to you. Do you have any dual energy? I mean, do you have any scanners that produce dual energy? Are you familiar? Any one of you here?
Yes.
Yes.
You have?
You have dual energy CT?
Yes.
And is it used in the clinical environment as a matter of routine?
Preclinical.
Preclinical, I see, okay.
Okay. But there are clinical at INCAN, at
Yes.
National Institute
Right.
of Cancerology, yes.
Right.
There's clinical. So to help to break the ice, I have a question. Is the information is being used only clinically or also as a research tool?
Well, as far as the vendors are concerned, that's where they started. The vendors or the companies, they started at that level, which is the level of research, which eventually was developed and became clinical. As far as hospitals, if you have it in your facility, we now started to have our own phantoms. We now created some new types of phantoms with different concentrations of iodine in there to verify if what they claim is really correct. It's one thing that we really want to make sure. And other things, we have also different instruments. We have, for instance, we look at kidney stones, and we try to separate kidney stones that are related to calcium or others that are easily phosphorus. And we found that this vendor, in particular we work with, they have some kind of inaccuracies. So our research goes now in the process of looking and being able to verify their numbers and make sure that what they are getting is similar to what we are getting, or the other way around, what we are getting is similar to what. So there's a lot of research potential in this particular area. Clinical, but also basic. You can really put materials in there, different concentrations of materials, different types of materials as well. Venture out and put different energies and see how those 190 keV, for instance, what is the advantage of going to 190 keV? You do not produce a 190 keV in real life when you have a spectrum, but you can produce it in theory and work with that. So yes, there is a good deal of basic research even that can be used using those scanners.
Thank you. Héctor. Yo te doy.
Hi, I don't quite understand how the dual detector modality CT works, since from what you said, the contrast of the image depends on the probabilities of the photons interacting with tissue, and that's why you need two energies. So you need two different beams. But this time you have only one beam and two detectors. So
yes, the two detectors configuration allows for the two energies to be produced, because the first detector will produce an image coming from like a routine image. I mean, if you start with 120 kVp, the first set of detectors, the first array of detectors will produce an image as if it is coming from 120 kVp in a single system. But the detectors behind that are going to see a filtered beam through the first array of detectors. And that filtered beam will produce an effective energy higher than the effective energy of the first image.
yes, I understand that, but the original beam is going through the body with the same energy in both cases. And that's where the interaction process occurs.
I see what you're saying. I understand. But the signal values obtained from that radiation beam are going to have different energies seen by those detectors. And therefore, the detectors will produce, in this case, different attenuation maps depending on the radiation beam exiting the patient.
Okay, thank you.
¿Tenemos alguna otra pregunta? Sí, Liz.
Hi. Besides iodine and calcium, what
Yes.
other materials are used to be separated?
They look at kidney stones, for instance, and differentiate one type of kidney stones from the others. They look also at hemorrhage, in the brain, secondary to ischemia. And so they look at iron content. So if there is a mass in the brain, for instance, CT shows a mass in the brain, and they want to figure out, is that really a real mass, or it just happened to have blood in it, so they can actually look at iron as another content, and evaluate if this is a real mass or it has blood, where the blood broke the blood-brain barrier and went to that particular part of the anatomy.
Thanks. And
Sure.
about contrast media, are they clinical contrast media based on gold?
On what?
Gold.
Gold, not in the clinical environment. They have not really used that. The contrast media we use is the same contrast media we use for regular type of CT work. So, yeah.
Thanks.
¿Alguna otra pregunta? No, no tenemos preguntas por el lado de los estudiantes de física. No, todo quedó clarísimo. Sí, tenemos una pregunta de física. We have a
Physics.
question from a physics student.
All right, physics.
Well, this might be an embarrassing question because I have no medical background.
It sounds good.
But I mean, I'd like if you could explain a bit more between the difference between contrast and noise ratio in the images, because to me all the images look basically the same.
Well, contrast has to do with the ability of differentiating between different pixel values, if you like. This is the closest approximation. So if two tissues have the same attenuation characteristics, meaning that over that anatomy you produce the same signal value here and the signal value there is no contrast. There is no separation between the two. Now, one of the things is that you may actually have excellent tissue characteristics that is likely to supposed to produce excellent contrast because of the variation in tissue composition and thickness and so on. But the fact that you have statistical fluctuation of the signal values due to the lack of photons, if you don't have sufficient photons, you produce some kind of a noisy image. Noise kills contrast resolution. Noise is actually going to be a factor in reducing the signal. Good contrast comes from good signal-to-noise ratio. If you increase the noise level, signal-to-noise ratio drops down, and contrast in this case is going to suffer. So noise is, again, something that has multiple sources. Whatever source it comes from is going to be detrimental to the contrast we are getting.
Thank you.
Sure.
Gracias. ¿Alguna más? ¿No? Entonces, agradecemos nuevamente al profesor Mustafa.
All right, thank you.
And we have some.
Oh,
Thank you.
All right.
And for your coffee or your tea.
thank you so much. Very nice. Great, thank you.